Swayam Prabha. Digital India. Educated India.
Hello, I am Dr. Shubha, Professor from Kempegoda Institute of Medical Sciences, Bangalore. Today, I will be talking about blood supply of the heart. Let us look at this case. A patient came to a doctor complaining of pain in the front of the chest which was moving on to his left upper limb on the inner aspect. The doctor told him most probably this pain is due to the involvement of his heart, and the patient was worried. Why is it moving to the left arm? I thought it was muscular pain. Doctor told, no, let us rule out the cardiac involvement. Why do you think the doctor told that there could be a possibility of the cardiac involvement? He explained to the patient that his coronary artery, the blood vessel which was supplying the heart, could have been blocked. This is the coronary artery which is supplying the heart blood supply, and this could be blocked due to deposition of a atheromatous plaque in the vessel wall. Okay? So, let us have a look at the coronary circulation. We will be talking about this topic of blood supply of the heart under the following headings. One is the arterial supply, which we will be covering in detail, which includes the coronary circulation, that is the right and the left coronary arteries, and we will talk a little about what is coronary dominance, which artery could be dominant in supplying the heart. When we tell blood supply, obviously it has to include the venous drainage. So, we will also cover the venous drainage, and we know that the main vein which drains most of the blood of the heart into the right atrium is the coronary sinus. So, we will be talking about this in detail, and we will also mention a few other veins which will be draining the venous blood of the heart. Coronary circulation, this topic will be covered under these headings. First of all, we will be talking about the coronary arteries, an introduction to these arteries which are going to supply the heart, and this will be discussed under the following headings. One will be the origin, the course, the relations of the arteries, how they terminate. Then we will be talking about the various important branches, because these branches could be involved in blockade. Then we will be talking about the area of supply of these arteries, and we will be talking about the applied aspects, because we need to know how this arterial blockage can result in various signs and symptoms. And lastly, we will be summarizing this topic. What is coronary artery? Why do you call this as coronary artery? The word corona means the crown. So, the word corona is the crown, and why has this coronary arterial supply named coronary? Now, when you look at these coronary arteries here, you can see they resemble an inverted crown. So, the artery is being named as coronary because both the arteries, when they are put together, they resemble an inverted crown, hence the name coronary artery. The unique feature of this artery is it fills up in diastole. No other vessel in the body gets filled during diastole of the cardiac cycle except for coronary artery, and this is a uniqueness of the coronary artery. This is also considered as vasa vasorum of aorta. Why do you think so? Because the heart develops from the heart tube, which is formed by the union of the two ventral aortae, and the ventral aorta is supplied by its own vessels, and these coronary arteries are supposed to be the vasa vasorum of these ventral aortae, which is going to fuse and form the heart tube, which on development results in the development of the heart. Lastly, the uniqueness of this artery is functionally it is an end artery. It is functionally so because there are certain anastomoses, but when you look at its function, these anastomoses are not enough to supply the blood to the heart unless they open up well. So, they are functionally considered as end arteries. Now, we will be going on to the topic of coronary arteries in detail. First, let us consider the origin, course and termination of the individual arteries. Now, we have a picture here showing the origin of the coronary arteries. This structure here is the aorta. The proximal portion of the aorta, that is the ascending aorta, has slightly enlarged portions which are called as aortic sinuses. There are 3 aortic sinuses. They are labeled as anterior and 2 posterior. The 2 posterior ones are called as the right posterior and the left posterior. You find this aortic sinus, which is a part of the ascending aorta, giving rise to the coronary arteries. So, the coronary arteries arise from the aortic sinus. Now, which aortic sinus is giving origin to the right coronary? It is the anterior aortic sinus. Anterior aortic sinus gives origin to this artery, that is the right coronary artery. This is also called as right coronary sinus in the clinical side. Whereas, this aortic sinus which is present here is the left posterior aortic sinus, and this is giving origin to this artery, and that is the left coronary artery. Left posterior aortic sinus is also called as the left coronary sinus. The arteries arise from the aortic sinus below the supravalvar ridge, which is present on the interior of the ascending aorta. Now, let us look at the right coronary artery. As soon as the right coronary artery takes its origin from the anterior aortic sinus, it is going to give off a branch which is going to supply the infundibulum of the right ventricle. This artery is called as right conus artery. Occasionally, right conus artery can arise directly from the anterior aortic sinus or the right coronary sinus. Then you find there are 3 coronary arteries, and this right conus branch will be called as the third coronary, which will take an origin directly from the anterior aortic sinus. So, this is seen occasionally. Otherwise, right conus artery is a branch coming from the right coronary artery. Now, this right coronary artery, after it takes its origin from the anterior aortic sinus, it runs downwards and forwards towards the right in the right atrioventricular sulcus. This is the atrium and this side is the ventricle. This is the right half of the anterior atrioventricular sulcus. So, it runs downwards and to the right. It lies between the right auricle and the pulmonary trunk. Between the right auricle and the pulmonary trunk. It runs downwards and to the right, continues to descend down in the right anterior atrioventricular sulcus to reach the inferior border of the heart. And when it reaches the inferior border of the heart, it is going to wind round the inferior border to start running in the posterior aspect of the atrioventricular sulcus on the right side. So, right half of the posterior atrioventricular sulcus it is going to run. What does it do? It runs on the posterior atrioventricular sulcus to reach the crux of the heart, and this crux of the heart is the junction between the atrioventricular sulcus, the interventricular sulcus and the interatrial sulcus on the posterior aspect. It crosses this crux of the heart, reaches the left side of the crux and ends here by anastomosing with a branch coming from the left coronary, and this branch is called as circumflex artery. So, it is going to end in the circumflex artery anastomosis, and that is to the left of the crux of the heart. This is seen in 60% of the individuals. In a few individuals, right coronary might end by continuing as the posterior interventricular, so at the crux, or it can end anywhere on the posterior atrioventricular sulcus before the crux, or it can end near the inferior border itself. But normal ending, what we consider, is to the left side of the crux of the heart by anastomosing with the circumflex branch of left coronary. So, this is the course and relation of the right coronary artery. Now, let us look at the course and relation of the left coronary artery. You find the left coronary artery taking its origin from the left posterior aortic sinus or the left coronary sinus. After this, it runs towards the anterior lateral aspect, running towards the left side between the left auricle and the left side of the pulmonary trunk. So, it lies between the auricle and the pulmonary trunk. It runs downwards and forwards. As it runs so, it will be very close to the mitral valve. So, during mitral valve replacement, this artery, when it is coursing this way, can get affected. It runs downwards and it has got a very short course. It is going to terminate by dividing into a circumflex branch and a anterior interventricular branch. So, there are two arteries which are the terminal branches of the left coronary, and this is the circumflex artery which is going to wind around the left border, hence the name circumflex, and this is the anterior interventricular artery which is going to lie in the anterior interventricular groove of the heart. The anterior interventricular artery gives off a branch very close to its origin, which is going to supply the anterior surface of the left ventricle. This runs downwards diagonally, and this artery is called as diagonal artery. Occasionally, this artery arises from the junction between the anterior interventricular and the circumflex artery itself. Then the termination of the left coronary becomes three terminal branches, resulting in three terminal branches. One is the circumflex, the other one is the diagonal, and the third one is the anterior interventricular branch. Otherwise, normally it is two terminal branches, and diagonal artery is a branch of anterior interventricular artery. The circumflex artery will wind around the left border of the heart and is going to pass on the left side of the atrioventricular sulcus and ends on the left side of the crux of the heart by anastomosing with the right coronary, whereas anterior interventricular artery will wind around the inferior border, and the junction here where it is winding round the inferior border, that part will have a slight depression because the anterior interventricular groove is going to end there, and that depression is called as incisura apices cordis. So, it winds around this, goes to the posterior aspect in the posterior interventricular groove, it ends by anastomosing with the posterior interventricular artery. So, that is about the origin, course and termination of the coronary arteries in general. Now, next we will be going on to see individual arteries, how they supply the heart, what are their branches. So, which are the most important branches given off by the individual arteries. Now, first coming on to the right coronary artery. The right coronary artery, now we have seen, has taken origin from the aorta, goes along the anterior right half of atrioventricular sulcus, winds round the inferior border, runs in the posterior atrioventricular sulcus right half till the crux. So, till the inferior border of the heart, you can call this part of the artery as the first segment, and beyond the inferior border, you can call this part of the artery as the second segment. So, let us look at the branches which come from the first segment of the right coronary. The first segment of the right coronary will give off atrial branches towards the right atrium. It will give off ventricular branches towards the right ventricle. On either side of the atrioventricular sulcus, these branches will run from the right coronary artery. Now, let us look at the ventricular branches. The ventricular branches will supply the sternocostal surface of the right ventricle, and the first ventricular branch is called as right conus artery. This right conus artery will supply the infundibulum of the right ventricle, hence it is called as right conus branch, and this might anastomose with a similar branch arising from the anterior interventricular artery, and this anastomotic circle is called as annulus of Wiesen's. Annulus of Wiesen's. Annulus of Wiesen's is the term used for the anastomotic circle which comes between the right conus and the left conus artery. It is called as annulus of Wiesen's. Anastomosis between the right coronary and the left coronary branches, that is the right conus and the left conus arteries encircling the infundibulum of the right ventricle, that will be named as annulus of Wiesen's. When we look at the anterior branches supplying the atrium, the right atrium, anterior branches supplying the right atrium, these branches will supply the sternocostal surface of the right atrium, and you find one of these branches which is given off initially, the first atrial branch to the right atrium, is called as sinoatrial nodal artery. It will pass medial to the right auricle, and then it goes in front of the superior vena cava and descends down in the SA node, which is anterior to the opening of the superior vena cava in the wall of the right atrium. It is going to descend through this and supply the SA node. This is called as SA nodal artery. This is seen in about 60 to 65% of the individuals arising from the right coronary. If it is not supplied by the right coronary branch, then it will receive a branch coming from the circumflex artery. The SA node will be supplied then by the circumflex artery branch, which has to take a longer route. The sternocostal surface of the right atrium and the right ventricle are supplied by the atrial and the ventricular branches. The last branch given off on the ventricular surface by the right coronary is the longest ventricular branch, and this branch will run parallel to the inferior margin. This is called as the right marginal artery. Arising from the right coronary, the largest ventricular branch, this is called as right marginal artery. It goes towards the apex of the heart. Next, the artery winds around and becomes the posterior segment or the second segment of the right coronary, and you find the branches arising from here. They supply the posterior surface of the right atrium and the right ventricle. The largest branch given off towards the ventricle is the posterior interventricular branch. Posterior interventricular branch will run in the posterior interventricular groove, descending down, and at the junction of the posterior 2/3 and anterior 1/3 of the posterior interventricular groove, you find the artery ending by anastomosis with the anterior interventricular branch, a branch coming from the left coronary. So, you find anastomosis taking place between the right and left coronary branches here in the posterior interventricular groove at the junction of posterior 2/3 and anterior 1/3. So, posterior interventricular artery normally about 90% of the cases will take its origin from the right coronary before its termination. And what does this posterior interventricular branch do? It gives off important branches which are going to supply the ventricles which are present on either side of the a posterior interventricular groove. So, it is going to supply the right ventricle and the left ventricle, and it also gives branches to the septum, interventricular septum. It is going to supply the posterior 1/3 of the interventricular septum. Anterior 2/3 is supplied by anterior interventricular artery, whereas posterior 1/3 is supplied by posterior interventricular artery septal branch. The junction between the two is posterior 1/3 and anterior 2/3. This is the junction here. The first septal branch coming from the posterior interventricular artery has got a looped course backwards. It runs recurring backwards towards the right atrium, and it is going to supply a node which is present here belonging to the right atrium. This is the AV node. It is a part of the conducting system of the heart. So, you find AV node receives a branch from the septal branch arising from posterior interventricular artery. So, now we can see the SA node and the AV node both are supplied normally by right coronary artery. The other septal branches will supply the septum, and the atrial and ventricular branches will supply the posterior surface of the right ventricle, a part of the left ventricle, and posterior surface of the right atrium. The terminal portion of this artery will give a few branch to the left atrium posterior surface and terminates by anastomosing with the left coronary branch, that is the circumflex artery. This is on the left side of the crux of the heart. These are the branches arising from the right coronary and its termination. Now, let us look at the branches which arise from the left coronary. Before that, let us look at what is the area supplied by the right coronary artery. So, when we look at the branches, we can see that the right coronary artery supplies the whole of the right atrium, greater part of the right ventricle. Why greater part? Because a small strip of the right ventricle adjoining the anterior interventricular groove, that is the sternocostal surface of right ventricle next to the anterior interventricular groove, is supplied by the anterior interventricular branch of left coronary. A small part of the left ventricle, where do you think it is going to supply a part of left ventricle? It has to be adjacent to the posterior interventricular groove. So, we know posterior interventricular artery in 90% of the individuals going to arise from the right coronary. So, posterior interventricular artery is going to supply a small part of the left ventricle adjoining the posterior interventricular groove. And how much of the septum it is going to supply? The right coronary, it is going to supply the posterior 1/3 of the interventricular septum, posterior 1/3, and what is left is the anterior 2/3, and that is supplied by the anterior interventricular artery, a branch of left coronary. It is going to supply the whole of the conducting system of the heart, including the SA node and the AV node. But there is an exception, as you can see here, and that is the left branch of AV bundle, which will be supplied by the left coronary. So, this is the area of distribution of right coronary. Next, look at the branches arising from the left coronary artery. Left coronary artery has taken its origin from the left coronary sinus here. It has got a short course between the pulmonary trunk and the auricle. Then it is terminating into the circumflex branch, which is going to wind round the obtuse margin of the heart, that is the left margin, and the other artery, terminal branch, is the anterior interventricular artery, which runs in the anterior interventricular groove. Now, this anterior interventricular branch, which is almost the continuation of the left coronary artery, will run in the anterior interventricular groove. As it is running, so it gives off branches to the right side, that will be the right ventricle. It also gives off branches to the left side, that will be the left ventricle sternocostal surface, and it gives branches to the septum. That is the interventricular septum. Now look at the branches coming from the anterior interventricular artery towards the right ventricle. The first branch may supply the infundibulum of the right ventricle, then that will be called as left conus artery. If this anastomosis with the right conus artery, a branch coming from the right coronary, then this anastomotic circle, as we have already mentioned, it will be called as annulus of Wiersens. Annulus of Wiersens. Next, you find the other branches of the left coronary on the right ventricular side will supply the small strip of sternocostal surface of the right ventricle adjoining the anterior interventricular groove. Look at the branches coming from the anterior interventricular artery to the sternocostal surface of the left ventricle. You find a branch which is arising very close to its origin, that is the longest branch running downwards and laterally on the sternocostal surface. This will be called as diagonal branch, the diagonal artery. It is going to supply the sternocostal surface of the left ventricle. The other branches also supply the sternocostal surface all along the left ventricle, and you find the other branches coming from the anterior interventricular artery will run backwards to the septum, going to supply the septum, and this will supply about the anterior 2/3 of the interventricular septum. So, you find anterior interventricular artery supplying the whole of the sternocostal surface of the left ventricle, a small portion of the sternocostal surface of the right ventricle, then you find it supplying the septum, that is anterior 2/3 of the interventricular septum. These are the branches arising from the anterior interventricular artery. The other terminal branch which we spoke about is the circumflex artery. It is called so because it winds around the obtuse margin of the heart, circumscribes the heart. The circumflex branch will run very close to the mitral valve. So, during mitral valve replacement, this artery can get injured. So, we should be careful in dissecting out the circumflex branch while doing mitral valve replacement. This gives off atrial branches and ventricular branches. The longest ventricular branch which is going to supply the obtuse margin of the heart is called as left marginal artery. Left marginal artery. It runs along the left margin of the heart formed by the left ventricle. The other smaller branches will also supply the sternocostal surface of the left ventricle, and you find atrial branches supplying the anterior surface of the left atrium. Occasionally it gives a branch which is going to replace the branch arising from the right coronary to this node. What is this node which is present here in front of the superior vena cava opening? This is the SA node. So, SA nodal artery, if it is not arising from the right coronary, then SA node will receive a branch which is seen in about 30% of the individuals arising from the circumflex branch. This branch then will travel anterior to the left atrium. It will wind round in front or encircle the superior vena cava and then reach the SA node. So, that is the SA nodal artery arising from circumflex artery in about 30 to 35% of the population. The other branch which is shown here in dotted lines is an anastomotic branch which can be present in some population. This anastomotic branch is an anterior atrial branch which will anastomose with an anterior atrial branch of right coronary. This will be passing, the anastomosis will be between the two in the anterior wall of the right atrium. So, this branch is called as Kugel's artery. This arterial branch is called as Kugel's artery. It is an arterial branch for anastomosis with a similar atrial branch coming from the right coronary. The circumflex branch then winds round the left margin of the heart, reaches the posterior part of the atrioventricular sulcus and ends by anastomosing with the right coronary to the left side of the crux of the heart. When it is doing so, here it will be supplying the posterior surface of the left atrium and posterior surface of the left ventricle. Occasionally, in about 10% of the individuals, you find the circumflex artery will end by giving off the posterior interventricular artery. So, this is seen in 10% of the individuals. Otherwise, normally what you see is 90% of the individuals, the posterior interventricular artery is a branch coming from the right coronary. So, 10% of the individuals, left coronary branch, the circumflex artery will end forming the posterior interventricular artery. This will decide the coronary dominance, which we will be talking about in the next few slides. So, you found this circumflex artery ending here. So, you find the left coronary area of distribution or supply is whole of the left atrium, a greater part of left ventricle. Why a greater part? Is because a narrow strip of left ventricle will be supplied, the diaphragmatic surface will be supplied by the posterior interventricular branch of the right coronary. A small part of the right ventricle, which small part is this? This is the part adjoining the anterior interventricular groove, because anterior interventricular artery will give branches to this small part of the sternocostal surface of the right ventricle. It also supplies greater part of interventricular septum, because it is going to supply anterior 2/3 of the interventricular septum. And in the conducting portion, it is going to supply only the left branch of AV bundle. But we can recall in about 30% of the population, it can give a branch to the SA node. Left coronary artery, if it gives the circumflex branch, and this circumflex branch, if it gives this branch, that is the posterior interventricular artery, then this branch can give a septal branch which will go and supply the AV node which is present here, AV node in the right atrium. Then AV node will be supplied by a septal branch arising from circumflex artery, which is in turn a branch of left coronary. Otherwise, normally AV node will be supplied by the septal branch arising from the posterior interventricular branch of right coronary. So, we have looked at the distribution of the left coronary artery. Next, we will go on to coronary dominance. Now, what is coronary dominance? Based on the posterior interventricular branch origin, whether it is taking its origin from the right coronary or the left coronary, we are going to tell which artery is dominant. When we tell it is right coronary dominance in 90% of the individuals, that indicates the posterior interventricular artery is a branch coming from the right coronary artery. This is seen in 90% of the individuals. Hence, we consider this to be the normal type of coronary circulation. Whereas, left coronary dominance is seen in 10% of the individuals when posterior interventricular artery will be arising from the left coronary artery, and that will be from the circumflex branch. Occasionally, you will find posterior interventricular arteries double, arising from both right coronary and left coronary, then it will be called as balanced type of coronary circulation. Balanced type of coronary circulation is the best to have, because there might not be any coronary arterial disease happening, because there is dual blood supply there. Even if it is one is blocked, then the other one will take over the supply. So, this will be the best type of circulation, but it is found to be very rare. Anastomosis helps to take over the circulation if there is any blockage. There are a lot of anastomosis between arteries, that is interarterial. It can be between the artery and the lumen of the heart itself, arterioluminal. It can be in the capillary level, or it can be between arteries, coronary arteries and extracardiac arteries like the esophageal arteries, branches coming from the descending thoracic aorta, mediastinal branches coming from the aorta. So, all these can anastomose with the coronary arteries. All these anastomoses will take time for them to have a better blood supply or blood passing through them. So, they need to open up. So, if there is a gradual obstruction, the anastomosis helps. If there is a sudden occlusion, this anastomosis is of no help because there is not much of blood flowing through the anastomotic channels, and this anastomosis will improve with age. Hence, you find there is lot of anastomosis developing in old age. So, you find old age people will have better survival rate when there is coronary occlusion. Next, we will look on to the clinical aspects related to coronary artery. Coronary arteries can be visualized by injecting a radio opaque dye to pass through them. How do you approach the coronary arteries? You need to pass a catheter through the femoral artery, and then a fiber optic scope will be passed through the arterial system, that will be the femoral artery, the external iliac artery, then through the abdominal aorta, through the thoracic aorta, arch of aorta, and once you reach the ascending aorta, you need to identify the opening of the coronary artery and inject the dye through this into the coronary arteries. Then when you take a X-ray, it will be visible. This is called as coronary angiogram. It is a contrast radiography of the coronary arteries. So, the picture which you get, the coronary angiogram, will show you how the blood vessels are supplying the heart, whether there is any block, where is the block present, all this can be identified by doing a coronary angiogram. So, this is a small procedure which will help us to know perfectly where the blocks are present. When you look at the coronary artery by doing an angiogram, you can identify a block, and this block can be due to atheromatous plaque. So, as the fat deposits present on the luminal surface of the artery will increase in thickness, and this will undergo certain changes with calcification, resulting in a condition called as atheroma. And this atheromatous plaque, once it keeps increasing in size, it will start blocking the vessel lumen, thereby decreasing the blood flowing through this. So, this atherosclerosis, the changes which take place in the arterial wall, can result in occlusion of the arteries, and since these are functionally end arteries, you find that there won't be much blood passing through these, and then it results in deficiency of blood supply or decreased blood supply to the distal portion, which is going to receive the blood from this artery which is getting blocked. Which are the arteries which are commonly getting blocked? You find the left anterior descending artery, and this left anterior descending artery is also called as anterior interventricular branch. This is seen in 40 to 50% of the blocks, the left anterior getting blocked, 40 to 50%. The right coronary, the next common one, seen in 30 to 40% of the population with the block, it is the right coronary being blocked. And lastly, 15 to 20% of the population, the circumflex branch will be blocked. When all these three are blocked, then it is called as triple vessel disease. A person will have severe symptoms and they need to create an extra channel for blood to pass through. With triple vessel disease, they need to have a better supply, and you need to give the supply by creating a channel which is going to bypass the block. Left anterior descending, which is most commonly involved in blockage, you find this happening in most of the men. Left anterior descending getting blocked, resulting in myocardial infarction. It can result in sudden death. Hence, this left anterior descending or the anterior interventricular artery is also called as the widow's artery. Once there is a block with insufficient blood supply to the myocardium of the heart, you find the patient getting pain in this region, and this can radiate along the medial side of the upper limb. This pain experienced when the patient is under stress, you find on exertion the pain developing and radiating to this region. Most often this pain is called as angina pectoris. Angina is for the pain involving the pectoral region, so angina pectoris. This is the characteristic pain which is developing in case of insufficiency of blood flow to the myocardium of the heart. But the pain can also be referred to the jaw. It can also be referred right side of the chest or shoulder or the right arm, or to the back. So, these variants can also be seen. Otherwise, normally it is seen as the retrosternal pain, the pectoral pain or the pain in the anterior part of the upper chest, and then shoulder pain which goes on to the medial side of the arm, forearm up to the fingers. This radiation of pain is due to involvement of the T1 nerve fibers which will be present in the medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm, which are branches coming from the brachial plexus having C8 and T1. So, T1 fibers will carry this pain sensation from this region because there is overlapping of T1 or the thoracic one spinal segments for both the heart sensation of pain and the medial side the skin sensory fibers. Once a person complains of insufficiency of blood flow to the heart with angina pectoris, and you do a coronary angiogram and you diagnose a block in certain region, if it is present in one or two arteries, then you can release this block by scraping the atheromatous plaque or the clot, by introducing a balloon which is inflatable into this region, dilating this so that it will transmit the blood in a better way after the procedure, and you can leave behind a stent to maintain the lumen. This whole procedure is called as coronary angioplasty. So, first you scrape and remove the clot or the plaque, introduce an inflatable balloon to increase the size of the vessel lumen, and then leave behind a stent to maintain the lumen. This is called as coronary angioplasty. If there are multiple blocks, then coronary angioplasty is of no use. What you need to do is coronary artery bypass graft surgery. It is also called as CABG, coronary artery bypass graft surgery. So, whenever there is a block, you need to overcome the block, you create a bypass, like how a bypass road will take you away from the traffic and put you across the congested area. So, if you find a block, for example, there is a block in the anterior interventricular artery here. Now, you need to allow the blood to flow to the distal part by creating a bypass. So, what they have done here is they have created a bypass by grafting a vessel to the distal part. Most of the vessels, arteries which are used for bypass graft surgery are internal thoracic artery, which is very close to the heart itself, or radial artery which is in the forearm because of its size. Radial artery size matches the size of the vessels here. So, it is easily graftable. So, you can use the internal thoracic or internal mammary artery or the radial artery. You can also use venous grafts. Most commonly, the vein which is used is the great saphenous vein. It has to be stripped out. It has to be made into a small luminal structure which is going to connect the aorta with the distal portion of the vessel. So, that is about the coronary artery bypass graft surgery, either using an artery or a vein. Now, let us look at the summary of coronary circulation which we spoke about till now. Coronary arteries are branches of ascending aorta. They are functionally end arteries, as we have seen, even though there is anastomosis till they open up. If it is a gradual process, otherwise they are end arteries. 90% of the population, you find the right coronary artery dominating, supplying more of the structure of the heart like the conducting system. A block in the coronary artery is commonly seen in the left anterior descending artery, 40 to 50%. This results in pain in the chest, which is called as angina pectoris. Angina pectoris pain is relieved on rest. It is present during exertion, relieved on rest. Or pain in the chest due to myocardial infarction, which is death of the cardiac muscle which is supplied by this artery. So, if there is no blood supply, it undergoes necrosis and death, that is called as myocardial infarction. This happens during rest, not relieved, but happens during rest, myocardial infarction. We also have seen that it can be visualized by injecting a radio-opaque dye and taking a picture of this radiograph. It is called as coronary angiography. This coronary angiography, if it proves that there are blocks in the coronary arteries, then it can be taken up for coronary angioplasty or coronary bypass surgery. So, that is about the coronary circulation. Let us look at the venous drainage of the heart. We all know all the organs will have blood supply, and the blood after utilization of the nutrition needs to be drained via the veins. Even the heart, this happens. We have seen 60% of the venous blood of the heart is drained by the largest venous channel which is present in the heart. This is called as coronary sinus. So, it drains about 60% of the venous blood. The remaining 40% of the venous blood of the heart is drained by smaller veins, which are the anterior cardiac veins and venae cordis minime. Venae cordis minime is also called as Thebesian veins. Anterior cardiac veins are 3 to 4 in number. They are present on the anterior surface of the right ventricle. They cross the right anterior atrioventricular sulcus and they open into the anterior wall of the right atrium, thereby draining the blood into right atrium. These are anterior cardiac veins. They end directly in the right atrium. There are smaller veins which are called as venae cordis minime or the Thebesian veins, which are present all over the heart, ending in all the 4 chambers of the heart. They are found more on the ventricular septum or the interatrial septum. It is more on the right side also compared to the left side of the heart. There are small openings which are present in the chambers of the heart, which will be called as foramina venarum minimarum, where the venae cordis minime will be opening. Now, let us look at this largest channel which will drain 60% of the venous blood of the heart. This will be talking under these headings. One is, let us introduce the topic first, then we will be talking about the length and course, the termination of the coronary sinus, the various tributaries, how it develops, and lastly summarize the topic. Coronary sinus is a large venous sinus which is present on the posterior surface of the heart in the left half of the atrioventricular sulcus on the posterior aspect. It is about 3 centimeters in length. It runs from the left margin of the heart downwards and backwards towards the right atrium, where it is going to open into by ending there. So, where does this open? It is going to open into the right atrium. It is going to open into the right atrium, and this opening will be between the opening of the inferior vena cava and the right atrioventricular orifice. Between these two you find the coronary sinus opening. This is guarded by a small semi-lunar valve in the inferior aspect. This valve is called as Thebesian valve. This opening is present in the lower part of the interatrial septum, lower part of the interatrial septum. It is just below the AV node. So, AV node will be somewhere here, just above the opening of coronary sinus. Now, let us look at the tributaries of the coronary sinus. The coronary sinus will receive on the left end this vein which is coming from the anterior surface. This vein is running in the anterior interventricular groove accompanying the anterior interventricular artery, starting from the apex of the heart running upwards towards the coronary sulcus, and this vein is called as great cardiac vein. It accompanies anterior interventricular artery. Great cardiac vein will wind around the left margin and end in the left end of the coronary sinus. Before it ends, it receives this vein, and that is the left marginal vein. Left marginal vein will end in the great cardiac vein. After receiving this, the great cardiac vein will end in the left side of the coronary sinus. You also find the coronary sinus on the posterior aspect receiving this tributary. This is the middle cardiac vein. It is on the posterior aspect in the posterior interventricular groove. So, it will accompany which artery? It will be the posterior interventricular artery. So, middle cardiac vein accompanying posterior interventricular artery in the posterior interventricular groove is one of the tributaries to the coronary sinus just before its termination. To the left of the middle cardiac vein, you find one more vein draining into the coronary sinus, and this is going to drain the posterior diaphragmatic surface of the left ventricle. It is called as posterior vein of left ventricle. Posterior vein of left ventricle. Just before its termination, you find the coronary sinus also receiving a vein which runs on the right half of the posterior coronary sulcus. This is called as small cardiac vein. This will accompany the right coronary artery. This small cardiac vein will receive this vein. This is the right marginal vein. Occasionally, right marginal can open directly into the right atrium. Otherwise, normally what happens? Right marginal will end in small cardiac vein will accompany the right coronary, and small cardiac vein will end in the coronary sinus before it terminates in the right atrium. You find this coronary sinus also receiving another vein from the posterior surface of the left atrium, and this is called as oblique vein of left atrium. Oblique vein of left atrium. This oblique vein of left atrium is the only tributary which is valveless. All the others will have valves in them. After receiving all these, the coronary sinus will be terminating by opening into the smooth part or the sinus venerum part of the right atrium between inferior vena cava opening and the right atrioventricular orifice in the interatrial septum lower end below the AV node. Now, let us look at this oblique vein of left atrium. You can see a fibrous cord connecting it to the left superior intercostal vein, and this is just before its termination into brachiocephalic. Left superior intercostal is connected to the left oblique vein of left atrium by a fibrous cord. This is a remnant of left duct of Cuvier. So, left duct of Cuvier gives origin to the oblique vein of left atrium and remains as a small fibrous cord. Now, you can see this fibrous cord is enclosed in a layer of serous pericardium, which will be called as ligament of left venum cava. Ligament of left venum cava. So, that is about the oblique vein of left atrium, which is on the posterior surface of the left atrium. Now, let us look at the development of coronary sinus. This is the heart tube. This is the lower end of the heart tube into which the sinus venosus will open. The sinus venosus is elongated transversely to create two horns, a right horn and a left horn. The two horns will receive the three big veins. One is the common cardinal vein or the duct of Cuvier, then the umbilical vein and the Wetline vein. Now, each horn will be present communicating with the central body. Body will be communicating with the rest of the heart tube. Now, you find the right atrium is formed by the absorption of the right horn and the right half of the body of the sinus venosus, which will give rise to the smooth part of the right atrium. The rough part of the right atrium will be formed from the primitive atrial chamber. Now, what is left is the left half of the body of the sinus venosus and the left horn. These two are incorporated by narrowing down onto the posterior surface of the heart, which results in the formation of the coronary sinus. So, coronary sinus develops from the left horn and a small portion of the body of the sinus venosus, and we have seen common cardinal vein giving rise to the left atrium oblique vein of left atrium with a fibrous cord remaining, connecting it to the superior intercostal vein. So, that forms the oblique vein of left atrium, and this is going to form the coronary sinus, that is the left horn and the small portion of the body of sinus venosus. Now, let us look at the summary of the venous drainage of the heart. We have seen that coronary sinus, which is situated in the posterior coronary sulcus on the left side, receives about 60% of the venous blood of the heart. And where does it open? It ends in the right atrium, because all the venous blood has to enter the right atrium. It develops from the left horn and body of the sinus venosus, and you find there are other veins which are going to drain directly into the right atrium without passing through the coronary sinus, and these veins are called as anterior cardiac veins and venae cordis minime. They will be entering directly into the right atrium, or in case of venae cordis minime, all the chambers of the heart. This is a heart specimen. To get oriented, this is the right auricle, this is the right atrium, and here is the right ventricle with the pulmonary trunk. So, this will be the infundibulum of the right ventricle with the pulmonary trunk. This is the anterior interventricular groove, and you can see an artery lying here in the anterior interventricular groove. So, this will be the anterior interventricular artery. This is the apex of the heart. This is the left ventricle. So, these three structures which are seen anteriorly will form the sternocostal surface. Between the right atrium and the right ventricle, you will find the right half of the anterior atrioventricular sulcus or the coronary sulcus. So, the artery which you find here is the right coronary. You can see the right coronary taking its origin from the ascending aorta here. So, this is the right anterior aortic sinus or the right coronary sinus of the aorta, giving rise to the right coronary artery. Now, the right coronary is descending down between the auricle and the aorta initially, and then between the pulmonary trunk and the right auricle, which descends down in the right part of the coronary sulcus. It reaches the inferior border and it winds round to reach the posterior aspect of the coronary sulcus, and you find the crux of the heart at the junction of the posterior interventricular groove, the posterior interatrial groove and the atrioventricular sulcus. So, it crosses this, goes to the left side of the crux and ends by anastomosing with a branch coming from this side. That will be the circumflex artery. So, you can see the left coronary here arising from the aorta. So, here is the right coronary, this is the right coronary arising from the anterior aortic sinus, whereas here is the left coronary arising from the left posterior aortic sinus. You can see the left coronary artery has got a very short course and it is terminating here into two. You can see the two branches here. This branch which is going to descend down into the anterior interventricular groove is the anterior interventricular artery. You can see one of its branch which is arising close to its origin is the diagonal artery. Is the diagonal artery. If this takes its origin from the termination itself, then it becomes trifurcation for the left coronary. Here it is arising as a branch of anterior interventricular artery. So, this is diagonal, this is anterior interventricular, and the termination is here of the left coronary. Now, you find the circumflex branch winding round the left coronary sulcus. It is going to the left side towards the left coronary sulcus. As it does so, it will be very close to the mitral annulus, and during mitral valve replacement the circumflex branch can get injured. You can see this crossing the left border of the heart. When it is crossing, it gives off this branch, and this branch is the marginal artery. This is the left marginal artery or the obtuse marginal artery coming from the circumflex branch which descends down on the surface. Beyond this, it is going to go posteriorly and end near the left side of the crux by anastomosing with the right coronary which is coming from the right side. So, left side of the crux is the junction between the circumflex artery and the right coronary. You can see a branch which is coming here, that is the posterior interventricular artery given off by the right coronary artery. In the posterior part of the coronary sulcus, you also find this. This is the coronary sinus. It is going to start from the left end of the sulcus, where it will receive the anterior interventricular groove vein which is lying here, and that is the great cardiac vein. It is going to end in this vein, that is the coronary sinus. So, coronary sinus is going to continue towards the right, reach the right atrium, and it opens into the right atrium between the orifice of the inferior vena cava. If this is the orifice of the inferior vena cava, this opening is the orifice of the inferior vena cava, then you find the coronary sinus opening into the right atrium between this orifice and the atrioventricular orifice. Here is the atrioventricular orifice. So, between these two is the opening of the coronary sinus, and it has a rudimentary valve guarding it. If this is the coronary sinus, this is the opening of the coronary sinus that can be appreciated here. So, this is the sinus which is coming here and opening into the right atrium at this junction, and there is a rudimentary valve guarding this which is called as Thebesian valve. So, that is between the opening of the inferior vena cava and the opening of the right atrioventricular orifice. Between these two is the opening of coronary sinus. So, this is the coronary sinus which is present on the posterior aspect of the coronary sulcus. Same can be seen in other specimens. To get oriented, this is the sternocostal surface. The surface which is sitting on my hand is the diaphragmatic surface. This is the apex of the heart. This is the pulmonary trunk. This is the right ventricle. This is the right half of the coronary sulcus. This is the right auricle. This is the aorta, and what comes out from the aorta and lies here will be the right coronary artery. Here is the anterior interventricular artery. This is the left auricle. This is the left ventricle. Here it will be the obtuse margin, the left marginal artery and vein. Here will be the acute margin, the right marginal artery and the vein. Posteriorly, what you see here is the coronary sinus. This is the coronary sinus. It has to come and open into the right atrium posterior smooth part here. This is the coronary sinus. So, these are appreciated well in these specimens. You can see the beginning of the coronary sinus here, the great cardiac vein ending in the coronary sinus, the coronary sinus continuing posteriorly going towards the right atrium, and it is going to open into the right atrium between the inferior vena cava opening and the atrioventricular orifice. This is the inferior vena cava opening which has been opened up here. This is the atrioventricular orifice. So, between these two you find the opening of the coronary sinus. Here is the opening of the coronary sinus guarded by a rudimentary valve, that is the Thebesian valve. So, that can be appreciated in this specimen. So, here are the arterial branches: anterioventricular artery accompanied by great cardiac vein, the right coronary artery posterior part accompanied by small cardiac vein, the posterior interventricular artery accompanied by middle cardiac vein, and you find marginal veins along the inferior margin is the right marginal vein, along the obtuse margin is the left marginal vein, that can be seen here. So, these are the arteries which can be appreciated in the specimens and the coronary sinus. So, with this we complete the topic on blood supply of the heart. Thank you.